two speakers, my colleague Becky Wilmer has a few announcements. Becky?
Thanks, Cindy. So currently audio is being broadcast through your computer speakers, and that means that the quality of the audio really depends on the speed of your internet. So if the audio is choppy, you can either find a more stable internet connection, or you can listen over the phone by dialing 866-835-7973. If you are listening through the phone, please mute your computer speakers to eliminate echo. Phone lines will be muted during the presentation to eliminate any background noise. Answers to frequently asked questions are in the webinar instructions pod that's in the upper left. And if you have questions or technical issues, you can type them into the Q&A box on the bottom left at any time. And after the presentation, we will pause for the presenters to answer your questions. We also have a PDF of the slides available to download above the slide deck. To download, you can click on PDF of the slides and then select the Download Files button to save the document to your computer. That's all I have. So back to you, Cindy.
Great. Thanks so much, Becky. Well, today we have two presenters with tremendous experience in this topic. I greatly appreciate our speakers for accepting the challenge of sharing their expertise with us in such a limited time frame. Following both presentations, we will take time for your questions. Our first speaker is Shanna Cox, the Associate Director for Science in the Division of Reproductive Health at the Centers for Disease Control and Prevention. Ms. Cox is responsible for the management, monitoring, and evaluation of the division's scientific portfolio. She has published extensively on a wide range of topics, including adolescent health, preconception health, and healthcare services. Ms. Cox worked with the National Children's Health Study to develop the research ethics policies and protocols for pregnant women and children. She has also served as a subject matter expert on agency and federal scientific clearance processes, survey data analysis, preconception health, adolescent male reproductive health, and the impact of healthcare reform on reproductive health. Our second speaker is Janine Brielle, the Director of the Substance Use in Pregnancy Initiatives for the West Virginia Perinatal Partnership. Ms. Brielle coordinates the work of several statewide advisory boards and committees focused on improving the health of mothers and babies affected by substance use, including tobacco, alcohol, and illicit drugs. She directs the Drug-Free Moms and Babies Project, an innovative initiative to provide integrated, comprehensive maternity and behavioral health services to pregnant and postpartum women. She also directs the work of an advisory group focused on improving the identification and care of babies diagnosed with Neonatal Abstinence Syndrome. Previously, Ms. Brielle worked as a program coordinator for West Virginia University's National Center of Excellence in Women's Health, and she was a senior policy analyst for the National Governors Association, where she directed a project on maternal and child health. I welcome both of you, and with that, I will now pass the platform to Shanna Cox. Shanna?
Thank you, Cindy. So good afternoon. I would like to thank everyone for joining us here today to talk about public health approaches to addressing neonatal abstinence syndrome. And first, I will present some epi data on opioid use generally and among women of reproductive age, and then also on neonatal abstinence syndrome, NAS. So opioid misuse has risen to epidemic proportions in the U.S., with more than 63,000 people dying from overdoses in 2016. This recent graphic from the New York Times, shown on this slide, demonstrates that the number of drug overdose deaths are higher than deaths due to car crashes, HIV, and guns at their peak. Data from a recent vital signs show that opioid overdoses in the emergency department continue to rise in both men and women, in all age groups, and in most states. Most states have seen an increase of about 30%, but in the Midwest, there are some states which have seen increases of up to 70%. This is also demonstrated in trends in delivery hospitalizations for pregnant women, where we see an increase from 1998 to 2011 in the frequency of deliveries that have opioid abuse and dependence documented at the delivery hospitalization. Opioid prescription use among women of reproductive age is common. Estimates of about 1/3 of reproductive age women have filled a prescription for opioid medication, and about 14 to 22% of women have filled an opioid Medicaid prescription during pregnancy. And in the U.S., every 3 minutes, a woman goes to the emergency department for prescription pain reliever misuse or abuse. And here we see the opioid epidemic is shifting, where now we're seeing an increase in heroin and synthetic opioids such as fentanyl playing a role in overdose deaths. So now that I presented on opioids, I'd like to describe the Neonatal Abstinence Syndrome, NAS, which is a drug withdrawal syndrome in newborns with exposure to these substances. And this can be seen in opioid exposure to prescription pain relievers, illicit substances, and also opioid maintenance therapy. And of note, with surveillance data, it's very difficult to disentangle which opioid is causing the syndrome. Symptoms include tremors, seizures, excessive or high-pitched crying, poor feeding, weight gain, and loose stools, and also increased sweating, temperature instability, and fever. Neonatal abstinence syndrome is also on the rise, concomitant with opioid use and misuse. And here we see an increase from 2000, where we saw approximately 29,000 infants with NAS. And in 2012, 1 infant with NAS was born every 25 minutes. There is also substantial variation by geographic region in the incidence of NAS, as demonstrated here from a map of the U.S. in 2012. When this analysis was performed in 2012 to 2013, you can see that many more states are shaded in colors of dark blue and gray, demonstrating higher rates of neonatal abstinence syndrome. And NAS treatment is costly. A mean length of stay of approximately 23 days and mean hospital charges of $93,000. It is estimated that it costs the U.S. $1.5 billion every year to treat infants with neonatal abstinence syndrome, with Medicaid being the most common payer. So now I'd like to talk about what CDC and others can do to reduce the opioid epidemic and address neonatal abstinence syndrome. Here I present a figure from Jean Coe et al. And the MMWR that discuss public health strategies to address neonatal abstinence syndrome. And at the top are interventions that may have a higher population impact, such as promoting responsible prescribing of opioids to women of reproductive age, providing access to evidence-based treatment for women who use opioids while they're pregnant, and things with lower population impact and a more third-tier prevention are providing appropriate treatment for infants with neonatal abstinence syndrome. And so I'd like to talk about each of these strategies here today. So first, in the preconception period, what are the strategies that can be used to address neonatal abstinence syndrome? And many of the strategies are strategies that apply to the general population that can be tailored to women of reproductive age, which include appropriate prescribing, prescription drug monitoring programs, and then decreasing unintended pregnancies among women who abuse opioids through preconception health care and delivery of quality family planning services. So this is a map that shows the variation of opioids prescribed per person among counties in 2015. And so there are 3 pillars of work that CDC is using to reverse the prescription drug opioid epidemic. This includes improving data quality and tracking trends, strengthening state efforts by scaling up effective public health interventions, supplying healthcare providers with resources to improve patient safety by supplying healthcare providers with data, tools, and guidance for evidence-based decision-making that improves population health. This is key to one of the 3 priority areas of the HHS Secretary's opioid initiative, providing training and educational resources to assist health professionals in making informed prescribing decisions. More specifically, CDC has issued guidelines for chronic pain prescribing, and we are working to get data quicker to drive action faster. We are looking for patterns of misuse through the Prescription Drug Monitoring Program, with the ultimate goal for all of this information to be integrated into electronic health systems and linked directly to coroners and medical examiners. So CDC clinical guidelines advise clinical providers to start slow and go slow when prescribing opioids for pain management. They also contain specific information relevant to women of reproductive age and pregnant women. Guidelines specific to preconception and pregnant women include: discuss family planning and how long-term opioid use may affect any future pregnancy before initiating opioid therapy for chronic pain for reproductive age women. Carefully weighing the risks and benefits with pregnant patients when making decisions about whether to initiate opioid therapy. Noting that medication-assisted therapy has been associated with improved maternal outcomes and should be offered for pregnant women with opioid use disorder. As noted, the Prescription Drug Monitoring Program are currently in 49 states, and they contain critical clinical data that can help identify patients at risk for overdoses and who are struggling with opioid use disorders, understanding what the total doses are across sources, and informing providers of other medications the patient is receiving to address doctor shopping. Studies have shown reduction in opioid-related overdoses and deaths in the general population, but as noted earlier, it's also been shown to be associated with shifts to illicit opioid use. In regards to improving preconception health, we know that nearly 50% of all pregnancies in the U.S. are unintended, but that figure is as high as 86% among pregnancies among women who abuse opioids. So really, increasing access to effective contraception among women who do not intend to become pregnant may be a strategy to reduce neonatal abstinence syndrome. Of note, we have to be careful with this strategy, as there is potential for coercion amongst this vulnerable population if delivery of care isn't patient-centered. But we have examples of where we've done this before. For example, the Choices program is an educational intervention where women had a choice to reduce their drinking or to use effective contraception. And at 9 months, we found that 69% of women reported reductions in alcohol-exposed pregnancies versus controls. There are also partnerships to provide education and family planning services at non-traditional sites, reaching women in drug courts upon release from incarceration, during needle exchanges, and during maternal addiction recovery centers. And you will hear from a presenter who will talk about some of the initiatives ongoing in West Virginia. So there are challenges to these strategies. The amount of opioids prescribed in 2015 remained approximately 3 times as high in 1999. PDMPs are not widely adopted due to provider time constraints, of lack of data integration into electronic medical records. And there are logistical challenges, patient preferences, reimbursement challenges in regards to integrating family planning and substance abuse treatment. In regards to the pregnancy period, there are also strategies that we can implement from a public health framework to address neonatal abstinence syndrome, including universal screening for substance use, access to treatment, and evaluation of concurrent substance use and comorbidities. The American College of Obstetrics and Gynecologists recommend early screening, brief interventions, and referrals to improve maternal and infant outcomes. They recommend that screening should be part of comprehensive obstetric care done at the first prenatal visit. It should be implemented universally and using validated screening tools in a caring and non-judgmental approach. But challenges include few screening instruments validated for use among pregnant women, debates on when and how often to screen, and use of biological specimens, and also varying state laws and policies. 23 states in D.C. require health professionals to report suspected drug use among pregnant women, and 7 states require them to test if they suspect drug use. In addition, there is an unmet need for referrals and resources. Also, the need to evaluate concurrent substance use and comorbidities, tobacco, alcohol use, depression, intimate partner violence. All of these are at play in regards to women who are struggling with opioid misuse and abuse. CDC is funding a survey among ACOG physicians to understand their knowledge, attitudes, and practice around treating women with substance abuse in pregnancy, and also looking to improve validation of tools. In the birth and neonatal period, there is a need for collaboration between prenatal care providers and pediatricians, improved identification of infants at risk for NAS, and standardization of evidence-based care. This can be used to reduce readmission risk, understand what the need for services to address long-term outcomes, and also working with families to develop safe care plans. So there are also challenges to addressing the needs of infants. There is limited data on readmission risks, and one of the things CDC is working specifically on is linking data in states to better understand what the long-term readmission and developmental outcomes are. There's limited evidence on the role of prenatal exposure on long-term developmental outcomes. And again, as mentioned earlier, with so many comorbidities and substance use and exposures in the environmental context, it can be difficult to disentangle the specific role of neonatal abstinence syndrome. So there is a need for collaborated and coordinated services for both the child and the family. The CDC is working to improve surveillance. Our Pregnancy Risk Assessment Monitoring System, also known as PRAMS, has substance abuse modules that can be used at the state level to monitor use of opioids and other substances such as marijuana during pregnancy. As mentioned, we are working with states to link birth certificate and Medicaid claims data to better understand what the health burden is, costs, and also long-term outcomes. Mental health and substance abuse are contributing factors to many maternal deaths. And so working with maternal mortality review committees to standardize the collection and the processing of this information when examining maternal deaths. Working to provide technical assistance to state health departments. And supporting efforts such as the State Perinatal Quality Collaborative to implement evidence-informed treatment protocols to improve outcomes for infants and reduce costs. So really my take-home message is it's going to take a village to address this issue from many different angles. Conducting surveillance and research, building state, local, and tribal capacity, providing providers, health systems, and payers with the information and tools that they need, partnering with public safety, and empowering consumers to make safe choices. So thank you, and with that, I would like to present the next presenter, Janine.
Thank you, Shanna, and thank you everyone for joining me this afternoon. I'm very pleased to talk to you about West Virginia and our approach to addressing NAS. So the first thing I'd like to just start with a little bit of an overview about our state. And the first thing I'd like to sort of assure you is that West Virginia is one of the 50 states. We're often confused with Virginia, but we are separate, and we're also bordered by Kentucky, Ohio, Pennsylvania, and Maryland. We're a relatively small state with about 1.8 million people that live here. We're the only state that is entirely in the Appalachian region of the country. We have about 20,000 births annually, though I will say that in the last year or so we've been seeing a decline in our birth rates. I think we're seeing more around 19,000 births annually now. We have 25 birthing facilities and 3 medical schools. This slide shows our 25 birthing facilities, and I just wanted 3 of which are tertiary care centers. I wanted to point out that many of these are along the border, which when we're dealing with this population, you know, brings its own challenges, especially if you're thinking about child welfare programs and making sure that the services are available and that someone's following and tracking these families. The other thing I wanted everyone to note is that we have a pretty large portion of our state that does not have a delivery hospital in it, which you know, brings a lot of other challenges having to do with access to care. In the last couple of years, we've lost 4 or more hospitals, and we're continuing to monitor that. So as I was introduced, I'm with the West Virginia Perinatal Partnership, and we're a statewide nonprofit organization that really works on improving health outcomes for moms and babies in West Virginia. This is our structure. We're kind of governed by a central advisory council. We're a perinatal quality collaborative in which we provide that neutral ground for folks to come together who are working on these issues. Our Central Advisory Council is made up of leaders in the field from the medical schools, from state agencies, insurance agencies, the head of ACOG for our state chapter, head of AAP, really folks that have the responsibility and the leadership role to make policy changes within their organizations. They guide the work of this perinatal partnership. The Central Advisory Council directs the work of the steering committee, which is basically the staff of the partnership, and the staff of the partnership works on quality improvement projects and committees. And that's who we are. So ever since we reformed, which was back in 2006, substance use in pregnancy has been identified as a major factor contributing to our state's poor birth outcomes. And I've been directing the work of the partnership in that area. I wanted to just take a few moments and ask the question of the audience. What is the most common substance used in pregnancy? You should have, if you could go ahead and answer that question. As I was saying, substance use in pregnancy has long been identified by the partnership as a major factor contributing to our poor birth outcomes. We collect our information from a key informant survey, and that's where we've looked at identifying where we should direct our work, what sorts of issues should we be paying attention to. We really go straight to the providers and folks serving this population and ask them, what do you see as contributing to this problem? Okay, looks like I think just about everybody has had an opportunity to answer, and it looks like most people got the right answer. So it is tobacco use in pregnancy. And the reason I wanted to just raise this issue is that because often when we're talking about drug use and substance use in pregnancy, we overlook tobacco use, which is the most commonly abused substance in pregnancy. It's clearly linked to poor birth outcomes, and it's a legal substance. And the other thing is I wanted to also just make sure you're aware that tobacco use in pregnancy complicates NAS. There's been studies that shown that women who have babies that are diagnosed with NAS, the babies have a longer hospital stay. It takes more, they need more treatment to manage their withdrawal symptoms. And as you can see from this slide, West Virginia has a very high rate of women who smoke in pregnancy. We're 25%, which is about triple the national average. And while clearly you can see this is our Medicaid population is where we see a lot of our smokers, it's worth noting that even in our higher income population, that is higher than the national average. So we have a lot of work and challenges here in West Virginia. And also talking about being number one, here's something else we're number one in, unfortunately. This is overdose deaths, which Shanna talked about, like the huge rise nationally in that. West Virginia is 41.5 per 100,000 in 2015, which was the highest in the country. And this is also a map she also showed, and something that we also have a high rate of, which is NAS. And in this study, which was published, we are 33.4 per 1,000 births. So, but when we started our work in 2006, it was early in the early years of the epidemic, really before anybody realized we were in the midst of an epidemic. And what we were hearing from our providers is that they were seeing lots of babies that were suffering through withdrawal after being born. So we started our work and we were like, well, what is the extent of the problem? Where are these babies coming from? How many are there? What should we be doing? And what we discovered is that we really had no good way to figure out how many babies we had that were being born with NAS. When we looked at our administrative claims data, which is the data that's used for this study, which is basically, how many babies got diagnosed with neonatal abstinence syndrome, the numbers were really low, and our providers are saying there's no way that's correct. What they were experiencing was that there were lots of babies in the NICU, and that they were having to turn babies away. The NICU was full of babies that they were having to manage for withdrawal, and then preterm and really complicated babies, they didn't have beds for them. So we took that information and we decided to do an umbilical cord tissue study to see if we could get a sense of how large the problem was. And what we found, which is what our doctors already knew, which is what it was a very significant problem. This study, which was done in 2009, it collected all the umbilical cords from every baby born in 8 hospitals around the state of West Virginia. And what we found is almost 1 in 5 tested positive for a substance. The problem was widespread. There was some regional variation in what substances were found in the umbilical cords, but notably most tested positive for more than one substance, which let us know that we had a lot of polysubstance use, and marijuana was the highest one besides tobacco, which wasn't tested. So now that we had this information, we had to figure out what are we going to do to address this problem. And what we knew is that if we had a healthy mom, we'd have a healthy baby. So we really decided we wanted to go upstream and look at what could we be doing for the moms in our state. So starting in 2011, we began to develop the Drug-Free Moms and Babies project, which is a public-private partnership. We had a private foundation collaborate with 2 of our state agencies and develop this model of care. They wanted to look at a comprehensive and integrated model of maternity and behavioral health care. So starting in 2012, and then the services that were part of the model were screening using the S.P.H approach, which Shanna mentioned, which screening, brief intervention, and referral to treatment, the comprehensive medical care, appropriate counseling services to address our substance use. We also wanted to include recovery coaching as part of the model and a 2-year follow-up after the delivery of the baby to make sure moms maintain sobriety, that they were continue to get the support and services they needed to prevent a second substance-exposed baby, and that also linking to home visitation programs to make sure that those moms were being followed and getting into the appropriate care. The model also included an evaluation. It was a pilot project. We wanted to make sure that these programs were effective, and so we included drug testing throughout the pregnancy, cord tissue testing for the baby, and a survey of the sites to identify strategies and barriers. So in 2012, we awarded 4 pilot project sites. The first was in at Shenandoah Valley. It's here in the eastern part of our state, in the Eastern Panhandle. This was a federally qualified health center, and it really represented a one-stop shopping model. Another site that we identified to be a pilot project was at Thomas Memorial Hospital in Charleston. So urban area. It was a hospital-based system with private providers that deliver there. Another was at Greenbrier Physicians. Greenbrier is a rural county that was serving a number of counties in the area. And the fourth site was at West Virginia University, a large tertiary care center in Morgantown that has a lot of resources, but also has patients coming from all over the state. So what we found after 3 years of operating these programs, that we were reaching a high-risk, medically underserved population. About a third of the women who participated in the program had less than high school diploma. They were low income. Over 90% were on Medicaid. The average age was 26. Most had never been married, and about 85% reported that their pregnancies were unplanned, which is I was noted was the same that Shanna said nationally what they see. But this slide shows is that tobacco use was the most common substance used by all the women in the program. Opioids was high, but also cannabis use. The program was successful in reducing drug use. We saw a decline from about 80% of the women who tested positive in the first trimester down to 20% at the time of delivery. About 83% of the women had a live term birth. Only 8% delivered prematurely, which is notable because our statewide average is 11%. So women who participate in this program had a better birth outcome on average than our more general population. Here's some of the lessons that we learned from operating this pilot project. It took more time to get the programs up and running than was anticipated, in that what every site found is that you really needed a dedicated person that played a key role in pulling all the pieces together and making sure that the project advanced forward. Care coordination or patient navigation, it's called different things by the different sites, but all of them, that was a key model. Part of the model. You had to have someone that provided that individualized coordination for each of the patients. A collaborative collaborative treatment team was necessary, but you really needed to develop and nurture that. It didn't just happen organically. Flexibility needed to be built into the model so that we could adapt to each of the community's needs and resources. And incentives were found to be really effective in keeping women engaged and just being a positive thing for them. We found, I heard from a lot of our sites that these women typically didn't have anybody ever do anything nice for them, so that was really appreciated and welcome. I am very pleased to say that our project was so successful that this year we expanded to 7 more sites. Now we have 11 programs around the state. Ideally, what we'd like to have is 1 attached to every delivery hospital, but we're moving in the right direction, and we're very excited with this expansion and the opportunity to serve more women. One of the other things that the Perinatal Partnership has been engaged in around this is helping develop some educational materials that providers can use with the population. Here's the one, it's a trifold that we developed to be used for women who are either pregnant or contemplating getting pregnant, and we have information about the effects of different substances on the pregnancy, the importance of prenatal care, some of the messaging, the importance of prenatal care, acknowledging that we know women may be scared to admit their use, but how important it is, and then how to get help. This didn't actually print very well, but it shows that we have a West Virginia implemented a toll-free line that can help locate treatment resources in the state. We also developed a set of pamphlets to be used for caregivers of babies affected by substance use. This shows, it has messages such as around safe sleep, caring for your baby once the baby's taken home. The inside talks about what NAS is, what to expect when the baby's born, how they'll monitor the baby, waiting for withdrawal symptoms, and then just how to care for the baby, how importance of quiet, calm, and gentle care, so not to overstimulate babies who are at risk for going through withdrawal. And this is the guide that we developed for our home visitors. I'm going to stop here, see if y'all still awake, and ask a question. Are babies whose mothers use opioids and other drugs born addicted? While you're answering that, I'll just say that West Virginia is fortunate to have a lot of both professional and paraprofessional home visitation programs available for pregnant and parenting women, and we're really trying to work with those programs in helping them understand the needs of these families, how to care for these babies, how to help those families know what to expect when they get to the hospital, how to work with their hospitals. Okay, we're done. I'm going to go ahead and give the results. The correct answer is false. It's somewhat of a trick question. Babies are not addicts, so they cannot be born addicted. Babies are born exposed or born dependent because their moms use, but they don't really meet the official definition for addiction. And one of the key things to keep in mind is an addict will continue to use despite negative consequences, in that, a baby is not going to continue to use because of negative consequences. Just briefly, I wanted to talk a little bit about some other work we've been doing around NAS. And in 2015, the Perinatal Partnership was funded to look at improving the care and our ability to track the prevalence and costs associated with maternal substance use. And what we were finding is, even a decade later, after we started our work, our administrative claims data still was not really reflective of the problem we knew that when we pulled the data, it was still underreporting how many babies were being born affected by substance use and going through withdrawals. And one of the things that we identified why that problem existed is that there really was no standardized definition for what neonatal abstinence syndrome was. As the first speaker talked about, it's really a constellation of different symptoms, but there's no like definitive, it's very subjective. There's no definitive blood test that baby would have or any other sort of test that says, oh, yes or no, the baby has NAS. So what we did is in the fall of 2014, we brought together some of our leaders, neonatologists, pediatrician, nurses, and others together to look at coming up with a standardized definition that we would use as a state to define what NAS was. And so this is what our pediatric community came up with. A neonate who has intrauterine exposure to a neuroactive substance and exhibits clinical signs and symptoms of withdrawal regardless of whether or not pharmacological treatment is required. So we took that definition and then we did an extensive provider outreach. We had a team of neonatologists representing the 3 different tertiary care centers that delivered training to every delivery hospital.
Okay, it seems that Janine has a little technical difficulty and she's calling back into the line. Please just hold for a moment. Thanks. While we're holding for Janine to call back in, let me just remind everybody that if you have questions for either of our presenters, you can go ahead and type those into the Q&A box at the bottom left of the screen. So take a moment to do that now while we're pausing. Thank you.
Okay, hi, can you hear me now?
Yes, we can. Go ahead, Janine.
Okay, I am really sorry about that. I got cut off.
No problems. No problems. You're back.
So I was just trying to get through the last couple of slides. I just wanted to let everybody know we did extensive provider outreach and education around the new definition. And we also implemented a surveillance system. Shanna talked about the importance of that and some of the work the CDC is in encouraging that. And starting in October 1st of 2016, West Virginia has what's called a birth score. That's a instrument filled out on every single baby born in the state. And starting in October of 2016, we added a couple of questions to that tool having to do with was the baby exposed and did the baby develop NAS, and it includes our statewide standardized definition. So this is a program as part of our West Virginia Project Watch that's a program of the West Virginia Office of Maternal, Child, and Family Health. And I just wanted to present a little bit of data that in the first 10 months of this collecting this information, what we found is we had 14% of the babies had intrauterine substance exposure, and 5.8 were diagnosed with NAS. And if you will recall the map that both Shanna and I showed, that our rate in West Virginia was 3.3%. So what we're finding is we're almost double that based upon what's being reported on our birth score. The birth score has a couple of added advantages. It's real-time data. It's electronically submitted straight from the hospital upon discharge. So it really gives us some very, we don't have to wait for our claims data, which can be a complicated, long system. So this is really going to give us the ability to track in real time what's going on in the state around this issue. And finally, I just wanted to close with, I feel remiss if I didn't mention Lily's Place, which is one of the only in the country types of studies. It's in Huntington, West Virginia. It's a non-hospital residential setting for infants who need treatment for withdrawal. What's going on in Huntington is that they found the NICU's the absolute worst place to try to manage babies who were experiencing withdrawal. They wanted to take them out of that high stimulated environment, so they were able to secure this location and convert it. So it's a beautiful place, and they provide wraparound services. I just learned today that they're doing some remodeling so that they can couple the moms and babies together, and also have a psychiatrist available to help work with the moms while the babies are going through withdrawal. So with that, I think I probably went over my time, but I'm happy to answer any questions.
Great. Excellent. What a great picture to end with. That's great, Jenny.
That's what we're hoping for. Strong babies.
Yes, strong babies, strong moms. So thank you. Thank you both, Shanna and Janine. It is now time to open the floor for questions. And again, if you have a question for either of our presenters, please go ahead and type it into the box at the bottom left of your screen, and I will read the questions as they come in. So we have a lot of great questions. We're going to start with a question for Shanna. Shanna, one of our participants comments, thank you for the USA data for NAS. Is there a good source that you can recommend to see the same type of NAS data on a county level? Is that possible?
No, at this time we don't have data available on the county level. HRSA does have data that states can go using their state inpatient data to get the state level data. And sometimes with the state inpatient data, there are some states that have county variables, but it's really not consistent across states. So that would be my first recommendation, is to look to see if you can get access to your state inpatient data, and if your state has a county flag in their inpatient data, and that might be a way for you to try to get county level estimates.
Okay, great. And while we're talking about data, could you also comment about the state prescription drug monitoring programs and what kind of access people have to information coming from those? Or does it vary by state?
That also varies by state, and what I can do is share some links with Cindy and folks that can be sent out to a larger group. Our National Center for Injury Prevention and Control, they're the main leads on the prescription drug monitoring program, and it really varies by state to state, what states, it's really something that a provider has to access in regards to being able to look to see if a person is getting prescriptions from multiple sources within the jurisdiction that the PMDP covers. And so again, it's really a way to kind of monitor prescription prescriptions for opioids in the state, to really help providers understand if they're adhering to provider guidelines around opioids, getting waivers, because, we are still in a place where people are managing chronic pain, and we don't want to take away the ability of providers to manage chronic pain, but also help them understand how patients may doctor shop and may be getting prescriptions from multiple places, and it's a way to kind of monitor and flag those occurrences in the system.
Great. Thank you so much, Shanna. Janine, a question for you. One of our participants wants to know, do you offer services for the children and follow-up care? For how long do you provide follow-up care for the mother? And do you connect them to federal programs like WIC, Early Head Start, Medicaid? And these are questions related to the Drug-Free Moms and Babies project.
Yeah, thanks for that question. Yes, I do have information. I didn't put it in the presentation, but where we're making referrals, and actually WIC was the one that was ranked highest among our sites where women got referred to. The intent is to follow them for 2 years after delivery, and they would be providing services for the family unit in making sure that the babies were referred to birth to 3 or early intervention, and any other services they may need. And really working closely with our home visitation programs that have a lot of experience in that area to make sure those services are received.
Great. Thank you so much. Okay. Shanna, we have another question about the one of the resources that you suggested, the CDC recommendations for providers for preconception and pregnant women. Can you talk a little bit more about what's involved in that and how people might access that information?
So actually, those are excerpts from the clinical guidelines for prescribing opioids. And so those are just excerpts from the overall guidelines that are specific for preconception and pregnant women. So really, and again, focusing on, for women of reproductive age, discussing family planning preferences, for pregnant women, carefully weighing the risk and benefits, and talking about medication-assisted therapy being recommended as opposed to abstinence for pregnant women with opioid use disorder. So there are not any specific guidelines specific for preconception and pregnant women for opioid misuse disorder. Those are just excerpts from the overall guidance for folks to be aware of.
Great. Thank you for clarifying that. Okay. And back to Janine, again regarding the pilot programs. One of our participants wants to know what incentives you may have used for the participants to elect to join the program.
Yeah, so they varied among the sites. Many of the sites used things for the baby, whether it was if you succeeded in staying with the program, you might get a stroller or a crib or a pack and play, things like that. One of the other programs reported using just personal care products for the women. That was one that kind of stood out to me because she talked about how a lot of these women just didn't have anything nice ever that anybody ever did for them, and so much they appreciated just scented lotions or nice candles, things that would be relaxing and help them, you know, if they're dealing with a very stressful time for any woman, but particularly a woman who's trying to address her addiction issues while she's pregnant. So those were the kinds of things they primarily were either for the mom, personal things to make her feel good about herself, or things for the baby that she would need. So.
Great. Thank you. And here's a question for either or both of you. Are you aware of materials or information for child care providers who might be caring for babies who were born with NAS?
Yeah, this is Janine. I mean, one of the home visitor guide and the pamphlet we did on caring for babies affected by substance use. You know, we've talked about working maybe with our CPS workers or our early intervention folks and doing some training with them around what they may be seeing or expect to see, but not beyond that. I know there's been some questions in our state, in West Virginia at least, but I'm not aware of any other resources.
Okay.
The Agency for Children and Families I'm sorry, the Agency for Children and Families, they do have some resources for families generally, but none that I know of that are specific for outside caregivers.
Mm-hmm.
But I'm sure many of the same strategies that they recommend would apply.
Mm-hmm. Okay. Well, thank you. It's a great question, and maybe there's something in the development pipeline that will come along before long. So we'll wait and see. Here's another question for either of you. One of our participants wants to know, how long typically do the NAS symptoms last?
That's an excellent question. This is Janine. I'll answer, and then Shanna, you can chime in as well. So what our providers will say is, and so it can take, we recommend, which the American Academy of Pediatrics has recommended, observing babies that are at risk for developing NAS for 4 to 7 days after delivery. So that's the guidance that we give our providers. Then if they do have NAS, and then they may treat, and the treatment can last anywhere from 2 weeks to months, just depending on what the baby was exposed to and how much. There's a lot of variation factors. And one of the things, and that's in the materials that we're trying to promote educationally to send home with caregivers, is that even though the doctor may they'll be treating the acute phase of withdrawal. So they will get the baby stabilized and tapered off and managed. But that doesn't mean the baby's never going to exhibit those same sorts of signs and symptoms. So they still may be fussy. They're just not going to be as fussy. What one of our leading neonatologists has said is that those sorts of symptoms can last on and off for 6 to 9 months after the baby goes home. And so I think that's the thing. We just want, caregivers to be aware of that so that they're learning how to manage those symptoms.
Right. Okay. Janine, there are a number of requests asking if the brochures that your partnership has developed are available to others, and if so, how can people access them?
Yeah, so we're working on getting those up on our website in a way that they could be, printed off and used, and we are more than happy to share those. Cindy, I'll share. Well, we're at www.perinatal.org is our website, but they're not up yet, and we're in the midst of redoing our website. So as soon as we do, we can get an email out maybe to everyone to let you know they're available. That sound good?
Okay, yeah, great. Thank you very much. Looks like we only have a couple more minutes. Here's one more question for Shanna. One of our participants asked if you could talk more about the opioid misuse data in the PRAMS system.
Yes. So in 2017, we funded 8 states, but a total of 16 states added information about prescription opioid use to their PRAMS survey. So PRAMS is a survey of women with a recent live birth that's sampled from the birth certificate, and it asks women about their experiences before, during, and after pregnancy. And the question asks, during your most recent pregnancy, did you take any of the following drugs for any reason? And part of the responses are prescription pain relievers such as hydrocodone, oxycodone. But it also asks about Adderall, marijuana, synthetic marijuana, methadone, Noxolone, maintenance therapy drugs, heroin, amphetamines, cocaine, tranquilizers, hallucinogens, and also huffing. So this is an additional question. If you go to Google CDC PRAMS and look up their questionnaire it's not a core question that every state asks, but it's a standard question that states can add on, and it's been cognitively tested at our National Center for Health Statistics if folks want to take it and adapt it to their own uses and surveys. So we have the question, some states have asked the question, have you used it during pregnancy? And some states also ask if they've used it in the month before pregnancy. So we're in the process of processing that data now and hoping that it'll be available for public use soon.
Great. Thank you so much. So we have come to the top of the hour, and it's time to close today's webinar. I want to thank our presenters, Shanna Cox and Janine Braille, for both fabulous presentations, and thank you, our audience, for your time. And finally, we do have a quick evaluation of today's session, and I hope you'll take a moment to complete this, and hope you enjoy the rest of the day. Thanks so much, everybody.
Thank you.